Hello everyone, welcome to my channel. In today's lesson, we are going to be looking at the nursing care of a patient with acute ischemic stroke and specifically patients who will qualify for endovascular therapy. We're going to be looking at the 4 to 24-hour anticipated order set and what will our role as nurses be. Endovascular therapy, or EVT, as it is also commonly referred to as, is an image-guided procedure for clot removal using a catheter which is inserted into an artery in your groin and threaded through your body up to the brain where that blockage is occurring. Always remember time is brain, and so this is done to restore blood flow to the brain as quickly and as thoroughly as possible. It is performed by specialists with neurointerventional expertise, and EVT has been shown to significantly reduce patient disability and a 50% reduction in the overall mortality compared with the current TPA treatment alone. It's safe, effective, and it's a very good treatment that saves life and dramatically reduces disability. At this time, there are only 10 hospitals in Ontario that provide EVT, and only 7 operate on a 24-hour basis. There are different treatment types for endovascular therapy, 5 of which include the microcatheter delivery of intraarterial TPA, stent retrieval devices, suction aspiration using the penumbra system, carotid stenting, and carotid angioplasty. And of course, this will depend on what is offered at the cardiac cath lab where you work. Inclusive criteria for endovascular therapy. Now, patients with suspected ischemic stroke arrive into the hospital 4 to 24 hours after stroke symptom onset, including stroke and awakening, or with unknown onset time, may qualify for EVT. Once eligibility for EVT is confirmed, you will be contacting Critical Ontario to request a consultation for EVT with the stroke endovascular team. Telestroke sites will access the telestroke neurologist through Critical prior to initiating EVT referral. The stroke endovascular team, in collaboration with the stroke physician, will assess cases for eligibility for transfer on a case-by-case basis and recommend transfer when appropriate. So you have now been asked to contact Critical Ontario at 1-800-668-4357. You will need to provide a callback number to the hospital, a direct line, the patient's name, their date of birth, their health card number, and then you transfer the call to the physician for medical information. Now, you may also be calling telestroke if it is that your hospital does not have stroke expertise on site, and this allows for access to consultations with stroke experts for acute stroke assessment, diagnosis, and treatment, including acute TPA and decision making for EVT. And this is where there's real-time two-way audiovisual communication that are in place to enable remote clinical assessment of the patient by the consulting stroke expert. So the physician will determine eligibility is met if all of the following criteria are positive. 1, these deficits are not pre-existing. Mild deficits that are now significantly worse are okay. So if before they had some right-sided weakness, but now they cannot move their right side at all, then that's a positive. Onset of symptom less than 24 hours. Now this can either be witnessed or the time the patient was last known to be symptom-free. They were living at home independently with only minor assistance. The patient must be completely independent with hygiene and personal tasks and walking. Now, it is okay if they were previously using walking aids. The patient does not have stroke mimics or another alternative explanation or diagnosis for symptoms. These patients will be arriving via ambulance, and if so, they'll be going straight to diagnostic imaging. You can accompany the patient to DI and insert the IV saline knot there, or sometimes the DI tech will be able to insert that. You will realize that they'll order non-contrast CT head stat or a multiplastic CT angiogram of the neck and the head stat. And this is normally acquired from the aortic arch of the vertex. Your role is also to notify CT to anticipate an emergent CT scan and enter the order as extreme emergent if the symptoms persist and the onset is less than 24 hours. Now, there are times when they'll order an MRI, but this will be much later, and it's also effective in excluding underlying hemorrhage and determining whether patients with acute ischemic stroke are candidates for thrombolytic or endovascular therapy. Chest X-ray may be ordered if clinically indicated, but bear in mind we're not delaying CT scan to do the chest X-ray, okay? Lab investigations. A capillary blood glucose upon arrival to the ED. You will also be drawing your blood glucose, CBC, HB1C, your Chem6 labs, lipid profile, beta HCG, troponin, INR PTT, and you're going to be drawing and holding those blood bank tubes. The National Institute of Health stroke scale score will initially be completed by the physician. We as nurses will be responsible for completing the Nursing Act Fast EVT screening tool. We will also be doing the Canadian Neurological Scale or the Glasgow Coma Scale every 15 minutes for an hour, then every 30 minutes. We will notify the physician if the patient experiences any changes in their GCS or CNS score, if the patient is having new, acute, or worsening headache, new hypertension, nausea, vomiting, or seizures. We will also be placed the patient on continuous cardiac monitoring and continuous SpO2 monitoring. Acute blood pressure management for patients who are experiencing stroke is very important because rapid or excessive lowering of blood pressure might exacerbate existing ischemia or might induce ischemia. And this is particularly important in the setting of intracranial or extracranial arterial occlusion. Extreme blood pressure elevation, so their systolic blood pressure is greater than 220 or their diastolic is greater than 120, should be treated, and you'll be reducing the blood pressure by approximately 15% and not more than 25% over the first 24 hours. It is beneficial to maintain BP within a specific range to avoid increased risk of bleeding and artery rupture associated with extremely high BP. Interventions that need to be initiated upon their arrival to the emergency department by the nurse include history, their age, time of onset of symptom, duration, presenting or improving, and when was the last time they were seen normal. Past medical history, coronary artery disease, coagulopathy disorders, cardiac dysrhythmias, previous TIA or stroke, diabetes mellitus, seizure, or epilepsy. Any medications that they're currently taking, any allergies, and you will also need to facilitate bedside registration. Additional ED nursing assessment include a full set of vitals, including focused neuro check. You will also be obtaining a 12-lead EKG, and again, you're not delaying CT for EKG. A 12-lead EKG is needed to assess for atrial fibrillation, concurrent myocardial infarction, or structural heart disease as potential causes or risk factors of stroke. You will also initiate social services consult for family if appropriate, and this patient will be no food, fluid, or medications by mouth until a dysphagia screening has been completed and documented. Now we are now at the juncture where the patient does qualify for EVT, or they'll be transferred to a hospital that will be providing endovascular therapy. You're going to review the patient's history, physical examination, medication, allergies, nil per os status or NPO status, and when they did last had something to eat, their weight, any neurological and cardiopulmonary assessments that you did, last set of vitals, including heart rate, blood pressure, your pulse ox, ventilatory status, and pain assessment. You'll also let the nurses in the cardiac cath lab know if they had any previous history of airway compromise or prior adverse reactions to sedation or anesthesia. Information on any treatments that were done before acceptance into the endovascular suites and the responses. Complications following endovascular stroke treatment will vary according to the type of stroke you've had and the type of treatment used. Some of these complications include pain, deep vein thrombosis, seizures, brain swelling, difficulty talking or swallowing, or cognitive issues. Now, comment below if you have ever been involved in a code EVT, what were your experiences? Subscribe if you enjoyed today's content.